This is Sergeant Bykowski with the Environmental Emergencies Chapter 12 presentation. When we go into environmental emergencies, we're going to talk about heat exposures, cold exposures, and then a little bit about allergic reactions, exposure to insect and animal bites. So as for any medical call that we go to as a first responder, always going to do our scene size up, make sure it's safe to be there and to start treating and assessing somebody. Our primary assessment, history taking, secondary assessment, and reassessment. As we often talk about with EMR, your initial assessment, what you'll be doing is first and foremost looking for ABCs and consistently monitoring your patient's ABCs as time goes on. And we've talked about it in the medical PowerPoint as well. Your traumatic emergencies, your traumas, car accidents, things like that, you're typically, after your initial assessment, are going to be going right into treatment, whereas medical emergencies, to include your environmental emergencies, after your initial assessment, you're going to go into some history taking, a lot more questions to narrow down what's going on, and then treatment, instead of the other way around for traumas. Heat cramps, that's your first minimal heat injury exposure. Typically you're going to feel those cramps in your arms and your legs first, because your body, once it starts becoming dehydrated to the point where it's going to start giving you cramps to tell you that something's wrong, it's going to be shunting all the blood and everything to your core to make sure that your all the important things in the core of your body, all your organs and things are well oxygenated and have good blood flow. So it's going to draw from your arms and legs, which is in turn going to make the heat cramps start there. They're going to be irritating, painful, not typically life-threatening if you pay attention to those signs and symptoms and rectify the situation with hydration. So when we're talking about heat emergencies in general, we want to move the patient out of that environment that's caused it into a opposite environment. So if we have heat-related injuries, heat cramps, we want to move them into a cool place. Typically, at this stage of the game, patients are going to be alert and conscious, maybe in some discomfort, but so what I would do is do a position of comfort for them instead of putting them into a position that you believe that they should be in. Position of comfort's typically going to work better for them. ABCs, oxygen therapy, encourage fluids, vitals, and then transport to the hospital for your minor heat cramps. Heat exhaustion is like your step up from heat cramps. It's when you're start becoming, it's going to be in your next slide here. That's when your body starts exhibiting more signs and symptoms due to the excessive heat. So that's going to be your profuse sweating, lightheadedness, dizziness, some altered mental status possibly, nausea, weak pulse, low blood pressure. As you can see, that's a step up just from the heat cramps, which is just like a pain or an aching of typically your legs and arms. This is kind of starting to affect the body as a whole, right? As long as you're sweating, that means that you're on the heat exhaustion stage. Once you go up from that and you go into heat stroke is when you're not going to be sweating. So that's a good sign. When you're sweating, your body is still trying to compensate for and is able to compensate for the environment that you're in. It's when that your body stops sweating and stops being able to compensate when we have a big problem. Just some extremely young and extremely old folks are typically going to be affected by heat and cold emergencies or environments faster than kind of like a young adult or adult age person, just because it's, you know, each end of the spectrum. Older people might have a lot of different diagnosis and disease processes that don't allow them to manage their like core temperature as well as young adults do. Treatment for us, like you said, is taking them out of that environment. ABCs, high flow oxygen, some passive cooling, which is like air conditioner, cool environment, maybe some cold packs on like the back of the neck, under the armpits, and the groin, and then transport to the hospital. Heat stroke is when the body's body core temperature is extremely high. Heat stroke could be deadly at times if it goes untreated. It's essentially like your body is cooking on the inside because your body temperature is so hot. Flush skin, dry skin, like I said, they're not going to be able to. Your body's unable to compensate for the environment that it's in, so you're not sweating anymore. You're bone dry. You're going to have altered level of consciousness. But as far as we're concerned, as EMRs, our treatment essentially stays the same. It's going to be maintaining our ABCs, high flow oxygen, removing the patient from the environment. If he's conscious and able to take fluids, you can try to give him fluids. But what they really need is to be cooled down passively and some major fluids, IV fluids. Soaking the patient in water is not something that you're going to do pre-hospitally. It might be something that they do hospitally for cooling. As far as we're concerned, like I said with the ice packs previously, you could put ice packs on them to try to get them start the cooling process. It's just a table to show different symptoms of both heat exhaustion and heat stroke. Moving on to cold emergencies, frostbite can definitely be serious, can be severe at times, but it's typically your first sign of cold-related emergency. It's going to be on the parts of your body that are typically exposed to colder weather, so like your face, your hands, your toes can get it. Same thing when we worry about susceptibility to these things, just like when we talked about heat emergencies, older age medical conditions. Things like that are going to make it easier for those people to sustain those injuries. Superficial frostbite is going to be like that. Your skin almost might look waxy, kind of like that white look to it. Obviously cold to the touch. The person may or may not have feeling, or maybe a reduced feeling in the affected limb, whether it's hand, face, or something. But the important thing to do is, the best thing to do is remove them from that environment into the opposite environment, so a warm environment, and passive warming, so that's like heat, have the heat on wherever they are, in the back of a car or ambulance, something like that. We don't want to start rewarming them by like rubbing the area to try to warm it up, because that could actually cause tissue damage doing it that way. And then it just goes into deep frostbite, which I had already mentioned, might look like white or waxy skin. And again, we're moving them into a warmer environment, passive for warming, not agitating their skin or anything. What they really need is to go to a hospital and get into what they call like a bear hugger. It's like looks like a big sleeping bag that has a bunch of fans that blow hot air into it to rewarm them that way. But with your deep frostbite or your severe frostbite, that's where you're most likely going to see the blistering to the skin. To that end, don't break the blisters or rub the area or apply heat. We got to do our ABCs, high level O2, try passively rewarming, and get them to the hospital. Obviously, with those injuries, we're worried about hypothermia, so it's easier to try to prevent hypothermia than it is to actually fight hypothermia. So that's keeping them warm. If they were in wet clothes, get those clothes off, wrap them up in blankets, heat on, things of that nature. It just gives you this is a table graph to depict what your core temperature is in association to the symptoms that they might be exhibiting. We have already kind of talked about it with the frostbite. A lot of your things are going to be the same. Your treatments, warm location, remove any wet clothing, blankets, heat, and transport to the hospital. Whenever we have a cardiac arrest with someone who's been exposed to extremely cold temperatures for an extended period of time, we'll always do CPR on those people. That old saying, you're not dead until you're warm and dead. So long story short, put it in layman's terms, the best way I can explain it to you is that the theory behind it is that if their core body temperature is extremely cold and the heart stops, we'll do CPR until we can get the person to a hospital where they could be their body temperature, their body core temperature can be brought up to a normal body temperature to see if the person can survive their hypothermia cardiac arrest. And the thought process behind it is that when your body goes into hypothermia, all your organs and body systems, they don't need as much oxygen to work when they're colder. So like that's why they're not metabolizing or using oxygen as much as they are when everything is warm and running at 100%. You're depressing the output of the organs when you're in hypothermia, so in turn you're not needing as much oxygen to keep them alive. So we used to do the same thing when I was a paramedic. If someone was in cardiac arrest and we got pulses back, we would induce hypothermia. So we would hook them up to cold fluids to try to reduce damage to body organs by putting them into almost a mild hypothermia state to cut down on the amount of blood and oxygen that the body system needs. So that's why you want to always do CPR, even if you find someone out in cold temperatures for a long time. Do CPR, get them to the hospital where they can rewarm them and see if they can bring the person back. Drowning and submersions. So drowning is essentially suffocation of water in the lungs. So, I mean, obviously it happens anywhere that there's water. So signs and symptoms of submersion injuries: coughing, vomiting, difficulty breathing, cardiac arrest, broken bones depending on what kind of water they were in, if they were trapped into in a waterfall, or if some sort of rapids or something, then they could sustain some sort of trauma. Obviously, if we can rescue them out of the water, we will try to do that. And then once we get them out, call for ALS, call for an ambulance, and you're essentially going to be assessing and treating based on what you have in front of you. But always keeping in mind our ABCs. If we need to breathe for the person, we will. If we need to do CPR, we will. Dry the patient. Even though that they were in water, if they're in cardiac arrest and you need to hook up an AD to deliver shocks, you can do that as long as we dry them off the best we can. Cold water drownings, again, even though if there might be a long downtime, we will still, with a cold water drowning, continue CPR, even if the downtime is extended period of time, and that's mainly due to the mammalian diving reflex, which slows the heart rate down and the metabolic rate down, decreasing the body's demand of oxygen, just like I was talking about with the hypothermia and the cold water hypothermia, cardiac arrest. Same kind of thing, same kind of principles, same kind of idea. Start CPR and continue until the person is delivered to the medical facility, just like we talked about. Lightning injuries or electrical injuries. So anytime we're talking about some sort of electrical shock or anything, there's always going to be an entrance and an exit, so keep that in mind. But again, as EMRs, we're kind of doing the same thing. We're doing our initial assessment, which is our ABCs. If we're going to deliver oxygen or breathe for somebody, we'll do those things, or CPR and defibrillate, we'll do those things. And then obviously the faster we can get them to the hospital, the better chances they have. Like I said, with that entrance and exit injury with the electrical burns or lightning strikes, there might be some sort of burns or trauma associated with that entry and exit. Should be aware of that. And then the bites and stings is talking about like bee stings. If we have someone who's having an allergic reaction, they got stung by a bee, we'll assist with ABCs, we'll assist with oxygen. We can assist them with taking Benadryl. If they have an EpiPen, we can assist them with an EpiPen. Obviously, if it's their EpiPen and they like prescribe to them, we will help them use that. But if it's just somebody else's EpiPen, we won't do that. It has to be theirs for us to assist them with that. Try to take the stinger out. If you see the stinger, they would say take the credit card and scrape it against the skin to try to remove the stinger, because the theory behind that is there could still be the poison in the stinger that's still going into the body if it's still partly attached. So that's why we would do that. And that is all for environmental emergencies.